I'm Dr. Harvinder, Kaur, gynecologist. I'm going to talk to you today about abnormal uterine bleeding. Abnormal uterine bleeding is defined as any bleeding from the uterus that is abnormal in volume, regularity or timing, or is completely non-menstrual in nature. So this covers intermenstrual bleeding, postcoital bleeding, and postmenopausal bleeding. For today's talk, I'll be focusing on menorrhagia. Menorrhagia has a variety of causes, and in assessing a patient, you will first have to rule out pregnancy. Common causes of bleeding in early pregnancy is miscarriage and ectopic pregnancy. Structural causes of the genital tract can cause abnormal uterine bleeding, and fibroids as well as polyps are the most common cause. Pelvic ultrasound is probably the best investigation to rule out these causes. Other causes are endometriosis, adenomyosis, ovarian cysts, and infection. In the young patient, you'll also have to rule out trauma or foreign bodies. In the pre-menopausal group of patients, you'd have to think about malignancy and pre-malignancy of the genital tract. Other causes of menorrhagia include polycystic ovarian syndrome, concurrent medications such as anticoagulants, and in the younger patient, coagulation disorders. So this would cover things like von Willebrand's disease, immune thrombocytopenia, and hemophilia. Specific systemic diseases such as hypothyroidism or Cushing's can also affect bleeding. So once we've excluded all these structural causes, the diagnosis of exclusion is primary endometrial dysfunction, or in the old days we called it dysfunctional uterine bleeding. This is a diagnosis of exclusion. This category is divided up into two parts, so 90% are anovulatory and 10% are ovulatory. Anovulatory bleeding is really common in the adolescent and in the perimenopausal group. The thought of the pathology of this is that there's not enough progesterone to stabilize the endometrium, and therefore proliferative endometrium is the result and abnormal bleeding. Ovulatory bleeding is cyclical in nature and very common in the reproductive age group. The cause of this is thought to be defects in the control mechanisms of menstruation. When assessing a patient with menorrhagia, it's important to get a thorough history, examination, and investigations led by that. When you're taking a reproductive history, determine the severity of bleeding. The frequent keywords that I use are flooding or clots. I also determine the severity of the bleeding on the quality of her life. Is she missing days of school or work with the bleeding? Important also to work out the duration, frequency, and amount. Other important things in reproductive history is the use of contraceptives, of the possibility of pregnancy, and STI history. In her medical history, elicit symptoms of anemia or symptoms of other endocrine diseases such as PCOS. Coagulopathies are something we should think about in the young patient. So 20 to 50% of adolescents with menorrhagia from menarche will have a problem. Patients in general that have a family history of bleeding disorder or frequent bruising or unexplained bleeding from the GI tract should be investigated. When examining a patient, exclude signs of anemia and signs of PCOS, which would include acne or hirsutism over the chest, face, or back. In doing an abdominopelvic exam, you're targeting looking for pelvic masses, an enlarged uterus suggestive of fibroid, for example, and a pelvic examination is to do specific testing such as STI swabs or a cervical screening test. It also completes the bimanual exam if you feel or see a mass. So, as you can see, there are a lot of investigations that we can do for menorrhagia, but the baseline is rule out pregnancy. You can do this via urine testing or bloods. As a baseline, you would do a full blood count and iron studies to determine the severity of bleeding. A pelvic ultrasound would be the first line imaging investigation. Ideally, you should do this transvaginally if the patient is sexually active, and ideally in the early follicular phase. Other investigations such as colposcopy, hysteroscopy, and endometrial sampling is really dependent on her history, examination, and ultrasound findings. In the treatment of menorrhagia, acute management of a heavy, hemodynamically unstable patient is in the hospital. So the patient would be fluid resuscitated and the bleeding would be controlled with IV Premarin, or in addition we might use IV tranexamic acid as well. If the bleeding is still continuous and uncontrolled, she may have surgery to have a D&C, or in certain cases fibroid resection or removal of the pathology causing the bleeding. For management of patients that are hemodynamically stable and have menorrhagia, the common thing we use is progestogen-only pills. So Primalute or Provera are used in a weaning fashion for these patients. So the thought is we are trying to stabilize the immature endometrium and arrest the bleeding. Patients should be aware that the bleeding will recur once the tablets are stopped. Doubling up her oral contraceptive pill is a handy way to stop bleeding, but this is rarely well tolerated due to the side effects of nausea. Non-hormonal treatments are very useful in controlling heavy bleeding. Tranexamic acid or cyclocaprin controls bleeding by up to 50%, and patients should take this medication 1 gram 3 to 4 times a day for the onset of bleeding. Non-steroidals such as Ponstan are also useful in arresting bleeding and work up to 50% as well. In the hormonal world of controlling menorrhagia, we divide up our therapies into the combined approach and the progestogen-only approach. The combined oral contraceptive pill can be used cyclically or continuously. The newer generation pills such as Zoli boast a better side effect profile and less breakthrough bleeding. NuvaRing is also useful in controlling heavy periods if the patient is comfortable to use this vaginally. Oral progestogens such as Provera or Primalute are good in controlling bleeding. However, they have a very low efficacy for contraception. So this is in the order of 80%. Implanon and Depot are better alternatives for contraception as well as period control. However, they do have an incidence of breakthrough bleeding. Visan is a specific progestogen-only preparation designed for patients with endometriosis. The mechanism is to reduce bleeding and produce amenorrhea. Not licensed for contraception as well, and a little bit expensive. The most popular choice in Australia is the Mirena, the levonorgestrel IUCD that covers heavy bleeding and also provides contraception. It boasts a menstrual loss of 90%, up to 90% in most women after 1 year. And the only issue with this is the spotting that can go up to 3 months from insertion. Other hormonal treatments that can be used are Zoladex or Cinorel, and these are GnRH analogues used in the endometriosis setting. So this causes medical menopause and cannot really be used in long term because of the risk of osteoporosis. So if patients are requiring this therapy for more than 6 months, they need add-back estrogen. It's not approved for menorrhagia when used on authority. A medication that came and went off our market is Esmia, so ulipristal acetate. This was marketed for fibroids, for reduction of size of fibroids as well as reducing menstrual bleeding. Unfortunately, it has been associated with severe hepatitis and therefore pulled off the market. However, it's still around as emergency contraception and marketed as Ella. So, with surgical management, the endometrial ablation is a non-morbid way of managing heavy periods, and the technology I use is NovaSure. NovaSure has a success rate of up to 80% of reduction of bleeding. The issue with this therapy is that some patients may require repeat therapy or may have recurrence of their bleeding after 3 to 5 years. It's also not ideal for women that have a distorted endometrial cavity secondary to fibroids or for cavities that are too large, generally above 10 centimeters. A hysterectomy is the most effective treatment for menorrhagia, but has surgical morbidity. Performing a hysterectomy via laparoscopy has reduced this risk somewhat. Satisfaction rates are upwards of 90%. My final slide covers management of various other structural abnormalities that can cause menorrhagia and its treatment. In specific, endometrial hyperplasia is common in the perimenopausal group or even the postmenopausal group, and therapies are largely progestogen only or a hysterectomy. Thank you for listening to my talk on abnormal uterine bleeding. As you've just heard, it's a very wide topic and it contributes to 2/3 of hysterectomies in Australia. So we have covered this in 10 minutes and thank you for listening. I am very happy to answer any questions that you may have via email, and there will be a link attached to this talk that you can use if you have any questions. Thank you.